Hi, I am Dr. Manik Copra. I am an interventional cardiologist and clinical lead structural heart disease interventions with Narayana Heart, and I am based at Ahmedabad. I am also proctor for MyValve. So transcatheter aortic valve replacement, or TAVR, is a technique by which you introduce a sheath. It is a tube-like structure into a major artery of the body, which is common femoral artery. From this we pass a wire which goes across the aortic valve, and over this we pass a balloon to crack the valve so that there is space, so that the valve enters. The native valve is being cracked so that there is some space, and transcatheter valve enters the native valve, and then we rapid pace and deploy the valve under rapid pacing. So it's a very simple technique, and once the procedure is done, we close it percutaneously so that there is no scar as such either on the chest or on the groin. So as any procedure has some degree of risk, some degree of benefit, we measure the benefit as well as risk. The risk involved is there is a chance of bleeding at the groin, there is chance of vascular complication, there is chance of cerebrovascular accident, there is chance of valve slipping up or valve slipping down, there is a chance that there is paravalvular leakage. So all these chances are there, but having said that, there are composite scores which give us the exact idea of the morbidity and mortality involved in the procedure, and then we compare the scores, and there are trials for similar scores comparing surgical aortic valve replacement with TAVR, and it has been clearly shown that across all the risks, low risk, intermediate risk and high risk, TAVR does as good as SAVR, and in many cases better than SAVR in degenerative tricuspid aortic valve stenosis. At the same time, TAVR is also better than SAVR, a redo surgery for patients with previously implanted bioprosthetic surgical valves at the aortic position. In general, patients of aortic stenosis, we basically calculate their risk scores like STS score or Euro score, which tell us that how much is the amount of risk involved in doing a aortic valve replacement surgically. So these risk scores were traditionally used for determining the risk, and we have many trials which are based on these risk scores. So most of the trials show that patients with inoperable risk or in high risk patients, TAVR is better than SAVR. This was again proven in intermediate risk, and now it is found to be equivalent or better than TAVR in low risk patients also. So all the patients of severe symptomatic aortic stenosis due to degenerative tricuspid aortic valves, TAVR therapy should be considered and is probably better than SAVR in most of the times. Having said that, we also need to consider many other factors which are not considered in risk scores, like for anatomical factors. For TAVR, for example, a very small femoral artery or access related issue, or the annulus size which is out of the sizes available for the valve, or the chances of very low coronary heights with bicuspid aortic valves. These are the cases in which probably surgery would be better. And for surgeon point of view, if the aorta is porcelain aorta or if there is radiation to chest, then definitely TAVR is better. So we need to consider the basic risk, and also we need to consider patient specific factors, and also the frailty and age of the patient, and then finally we discuss all these things with the patient. There are local issues as well as whatever the therapies are available, and finally we decide what therapy is best for the patient. Transcatheter aortic valve replacement is there to stay. It has a long journey of last 10 years, starting from inoperable patients reaching up to low risk patients. I see this therapy to grow in developed as well as developing countries in near future. The cost of therapy definitely would be a constraint for India, and as the valve costs will go down, definitely the treatment is going to be taken by more and more patients. It will reach more and more people. having said that, I also understand that transcatheter therapy is growing at all the other positions like mitral, pulmonary and tricuspid, and after maybe 15 or 16 years we would find situation of surgical versus transcatheter treatment for valvular heart disease similar to PCI versus CABG for coronary artery disease.